Hi guys, earwaxspecialist.co.uk here again. Interesting case that came into clinic this afternoon. It's a patient that we've seen a couple of times before, and she suffers with this dead skin and keratin, which almost adheres itself onto the actual eardrum itself. So here, what I'm doing is I'm using a fine end, which is slightly smaller than the sort of normal 2 millimeters ulnar that we would normally use inside the ear canal. Because we're working in the last third of the cavity, we're working on the eardrum, we have to be incredibly delicate, and the nature of the sort of obstruction is such that we have to make sure that we're using a cannula with reduced reduction, and also it's a lot less noisy, especially when you're working this close to the eardrum or on the eardrum. You don't want to cause any long-standing issues with tinnitus or aggravate any tinnitus that's pre-existing. So we're peeling this away. We're here at that sort of almost superior sort of rear quadrant there, just sort of peeling, and I'm trying to sort of just almost flick out this piece of dead skin which is adhered towards that bony part of the canal there. Just there, you'll notice towards that right posterior wall on the right side, just lifting it off. And a lot of this is sort of stuck in the recess at the back of the ear as well. So you're almost sort of trying to lift up and out rather than just sort of trying to bring it away laterally, which isn't always easy. So there we go, more of the eardrum visible now. And again, we're going up into that sort of superior quadrant. They're just trying to just knock it off very, very gently. The key is good control with the suction cannula. I tend to hold it like a feather just in case, we nick the ear canal. It's a very, very sensitive part of the ear. You find a tremendous amount of sort of sensory nerve activity that runs through there. I mean, you've got, the facial nerve, the vagus nerve and cranial nerve number 9, 5, and the sensory sort of fibers running all the way through the middle ear, and of course also into the acoustic meatus itself. So there's a lot of touch, temperature, pain receptors that run through this. So you have to be very, very gentle when you're doing this type of sort of earwax removal. So again, just gently trying to peel it off. And this just requires a degree of patience. You just can't force it. You have to just take your time and just remove away a little bit at a time. And you'll often find that you'll find a fold or a crevice. And the moment you sort of latch onto that, it sometimes brings the whole lot away. So now I've moved away from the back of the ear, just trying to remove some of this dead skin now towards the medial sort of wall of the ear canal. And again, you'd think at this stage it looks pretty clear, okay? So I'm just again picking away at a few bits and pieces there, just in that almost inferior anterior recess at the back of the ear. And this was quite surprising for me actually. So as I was sort of moving some of this dead skin away, at this point I thought, that's a pretty good job. Patient was responding well, advised that she was actually hearing a lot better. But then I decided to sort of move up into that sort of superior sort of posterior wall of the canal in a second. Not just yet, I'm just sort of cleaning the sort of medial wall there. And I just noticed that there was a little bit left at the top of the cavity, so I thought, let's see if we can sort of bring that away. So in a second, after I've tried to sort of remove the remnants of this dead skin in the medial walls away, I sort of tend to sort of head towards the back of the ear again, and to my surprise, there was a whole sheet of dead skin which just sort of came away in one large piece. So at this point here, I'm just trying to move it off. Again, we have to be incredibly gentle here. The ear canal, especially that last third, I mean, there's a lot of sensory fibers running from your facial nerve that actually run through the acoustic meatus. So it's incredibly sensitive to sort of cold and sort of touch, and sort of a lot of temperature sensors in there as well. So this is why a lot of patients sometimes come in with a huge degree of symptoms, not necessarily just hearing loss. There we go. That was the moment where I just sort of lifted that fold away from that sort of superior sort of right posterior wall, and there you go. It's just come away in one go. And I'm now just sort of bringing it into the middle of the ear, away from that canal wall, and hoping to just sort of get a little bit more suction, because I've got a little bit more surface area to work with now. I've moved it away from that right posterior wall, and there we go, it's starting to come away now. And I'm just sort of picking at it, just gently trying to move it off, and in a second I'll get the desired suction I need. And I think, there we go, just trying to find that point. You don't want to sort of push it too far back, especially when it's loose inside the ear like this. You often sort of have this game of sort of to and fro, but you want, there we go, it's just come away there, and that's it.